Aortic regurgitation is surely an under-recognized disease. It's only treated until last year actually by aortic surgery and in a rare number of cases, compassionate use with transcatheter TAVI. In these cases, we had to oversize the valves significantly. Now, with a new valve design by TAVI with the JenaValve, we're able to treat more and more patients and to give them a secure also outcome in relation to minimal PVL or no PVL. So I think a very good option to be seen like in aortic stenosis over the time course of the next 5 to 10 years in younger and younger patients, and in patients coming from high risk to lower and lower risk over time. TAVI was originally designed and also used for severe and life-threatening aortic stenosis, initially in inoperable patients, then high-risk patients, then moderately at risk, and then low-risk groups over the time frame of 20 years. When we look into aortic regurgitation, we have a different seating and also a different sealing in the stent frame. We don't have the problem of non-circularity because the tissue typically is soft, but we have to anchor twice and we have to engage the leaflets. And this is a specific option of the JenaValve, that we have feelers that commissurally align, allow a perfect anatomic seating, good coronary access, but also stability from a pop-off of this valve, neither into the aorta nor into the ventricle, which is extremely important. So in totality, we have a huge trial, 180 patients, continued access in the US, and we have commercial experience in Europe that exceeds 100 and approaching the 200 next year. So I think the overall setting shows that this valve works well in a real-world setting. I'm very encouraged, and you can see this, that our site is one of the 2 largest sites in Germany and in Europe at the same time to implant this valve. When we have added this in a portfolio of 5 different TAVI designs that we currently use and enable at our institution, it has become a remarkable and even larger than expected proportion, which exceeds already with a focus on AR, has a 2-digit number as a percentage of our TAVI valve implants. And I think this is extraordinary in a valve that has just received CE mark and that is new on the market. So I think this shows the stability, but also the intelligent and very special design of this valve to treat special anatomies and AR. Aortic regurgitation is special, especially in a European or Western world scenario, where size of the patients is ever increasing, and also the annulus size, of course, in AR is larger than in the stenosis field. So while we're already able to treat a large proportion of the patient population, the largest size is currently 27, which treats up to 29 millimeter derived from the perimeter. We're looking forward, I think, as a next iteration to also see larger valve designs, so one larger size, in order to get across the 30 millimeter margin in the patient treatment. I think we will move forward, and of course we have to see and show durability of this valve design against and with surgical options. And I think there will be a new leveling out between surgery. So I think younger and younger patients, especially if TAVI and TAVI works excellent with this valve, may come into the focus also in aortic regurgitation. And I think the patient population will benefit from it with less invasive treatments, minimal invasive approaches of the heart team. And we have to do this together with our fellow heart surgeons and cardiologists in order to achieve the best results for every age and every risk group, not only in aortic stenosis, but now also transcatheter based in aortic regurgitation.